Hi, I'm Chad Deal. I'm Associate Professor of Medicine at the Cleveland Clinic Lerner College of Medicine and head of the Center for Osteoporosis and Metabolic Bone Disease at the Cleveland Clinic. My job today is to review and update information from the 2011 ACR meeting on osteoporosis. So since there are lots of osteoporosis information of necessity, I had to make some choices about what we presented today. So I'm going to talk a little bit about Denosumab because there was more information at the meeting on Denosumab, and it's the newer osteoporosis medicine in town, but we'll also talk about Teriparatide and some things about adherence to therapy and treatment of patients with established hip fractures and with steroid-induced osteoporosis. The first slide here is just an introductory slide about Denosumab. Remember, Denosumab is a fully human monoclonal antibody against rank ligand, a very critical cytokine for osteoclast development. The product was released in June of 2010. It's given as a subcutaneous injection every 6 months. And it's an anti-resorptive agent, just like the bisphosphonates, except with a different mechanism of action. And it has a very rapid offset of action, in contrast to bisphosphonates, which bind very avidly to bone and remain in bone for extended periods of time. This is a slide that shows what happens when you stop Denosumab on markers of bone, both resorption, that's serum CTX, and bone formation, bone-specific alk phos, or BSAP. So in the slide to the left, you can see the patients were given doses of Denosumab at 6, 12, and 18 months, and then discontinued. And you can see at 24 months, the serum CTX is still more than 80% suppressed, as you would expect an anti-resorptive agent to do. But then within another 6-month period after discontinuation, so that's about a year after discontinuation or last shot, you can see that the serum CTX is almost 60% higher than even the baseline value. And you can see a similar trend for BSAP on the right, a marker of bone formation. And this hyperresorptive state that occurs after discontinuation of Denosumab has led to some concern about increased risk for fracture after discontinuation because of this hyperresorptive state. Well, that was addressed in the Freedom trial, and you can see here this is the Denosumab discontinuation and fracture incidence in the Freedom trial. The Freedom trial is a 3-year randomized control trial that led to the approval of Denosumab. And here we have 2 graphs. The graph on the top, you can see the fracture incidence, percent of subjects with a fracture on placebo, and again on the bottom, the percent of fracture patients who discontinued Denosumab. And at the bottom, you can see this is months since ending treatment, last dose day plus 7 months. So the 6-month figure would be 13 months after the last dose. And you can see the fracture incidence is equal at that point. But over time, actually, even after discontinuation of Denosumab, and even with that hyperresorptive state that I showed on the previous slide, the fracture rate was lower than placebo through about 31 months, 24 months plus 7 here, which is reassuring. A late-breaking abstract, number 8, was the 3-year extension of the Freedom trial. At the end of the 3-year Freedom trial, all patients were offered an additional 7 years of therapy, and that's called the extension trial to Freedom, or the Freedom trial. We have a 3-year update on that, so this is a cumulative 6-year experience with Denosumab. So 4,550 women out of about 7,800 women enrolled in the extension trial, and you can see the lumbar spine increase, bone density increase after 6 years was very robust at 15.2%, and total hip at 7.5%. Interestingly, there were cases of osteonecrosis of the jaw, ONJ, through the 6 years. In the first 3 years of the regular Freedom trial, there were no ONJ cases. And in the 3 years since then, there have been 2 cases in the placebo group that were switched over to denosumab and the patients who received 6 years of denosumab in this trial. So like all the anti-resorptive agents, O&J may be a concern, especially in those patients who've had oral surgery, although the rate of O&J is quite low with all the anti-resorptive agents. But it certainly bears watching. Another concern with denosumab has been the risk for infection. As you know, in the FREEDOM trial, there was an increased risk of cellulitis or erysipelas, as they call it in Europe. And you can see in the top part of this slide, we're looking at the FREEDOM trial year 1, year 2, and year 3. And we're looking at cellulitis in year 1, year 2, and year 3. And you can see there were 13 cases of cellulitis in the first 3 years. And in the extension trial, and this is the 2-year data on adverse events, the goal here was to compare the exposure-adjusted subject incidence per 100 subject years in the extension trial with what we saw in the first 3 years. And reassuringly, you can see that in the extension period, there were only 3 cases in 2 years of cellulitis or erysipelas, and that rate appeared to be lower than it was in the first 3 years, indicating that there did not appear to be any significant signal for increasing infection over time. And the same was true here with bronchopneumonia and lower respiratory infections. And on the next slide, you can see all SAEs of infection with this rate adjusted per 100 subject years of 1.5, 1.6, and 1.6 in years 1, 2, and 3, and then 1.3 and 1.2 in the extension period, again showing no significant uptick in the risk for infection. Denosumab also had a phase 2 trial, and this phase 2 trial in 262 patients in the parent study has been extended out through 96 months or 8 years, and you can see the increase in lumbar spine density on the top here is 16.5% over 8 years. 200 enrolled in the long-term extension after 4 years, and 138 have completed 8 years, so this data is representative of those 138 patients who've completed 8 years. And you can see the bottom line here represents patients who were on placebo in the first parent study, and then denosumab was added, and you can see the increase in bone mass, which kind of parallels the rate of increase that we see in the top graph on patients on 8 years of therapy. This is the same data I'm showing you in the total 8 years in this phase 2 long-term trial. You can see the total hip density here is 6.8%. So porosity is a very important consideration in terms of the effect of both bisphosphonates and teriparatide or PTH therapy. What you're looking at on this slide is what we call cortical bone or Haversian bone, and you can see the center, the dark area, represents the vascular channels, and the concentric rings around those dark areas represent the laminar structure of the Haversian canal with interstitial bone in between all the Haversian canals. And those little holes that you see in the laminar structure around the central canal represent pores. Those are areas of remodeling. And parathyroid hormone, or teriparatide, increases turnover and increases cortical porosity. And the bisphosphonates and anti-resorptive agents decrease turnover and actually decrease cortical porosity. So interestingly, this study compared placebo, alendronate, and denosumab for cortical porosity. And you can see that compared to placebo, alendronate decreases cortical porosity. Denosumab decreases cortical porosity even more, 8.81% versus placebo and 5.8% versus alendronate. This decrease in cortical porosity is probably very important in terms of strength. Less pores is likely to mean more strength in cortical bone and more resistance to fracture. Denosumab appears to do a better job at decreasing cortical porosity than at least alendronate on the bisphosphonate side. All right, let's go on and talk a little bit about teriparatide, and before I do that, I want to just introduce this concept of finite element analysis. This is a schematic of a bridge you see on this slide, and it's divided up into voxels, and this is what engineers do in order to determine the strength of a complex structure. So they model the structure, they put it in these little voxels or finite elements, and they assign material property to each element, and then by computer apply external forces to the whole model and compute the strength. And of course you can do that with a bridge, as you see here, or you can actually do it with a vertebral body, as the data shows here. This is the effect of teriparatide based on finite element analysis. So we're looking at the strength of 18 months of therapy with teriparatide in the vertebral body, number n equal 30, and the femur n equal 26. And you can see the strength of this vertebral body increased 16.6% versus 2.3% in the femur. Down on the bottom, you can see aerial bone density. That's a DEXA scan. The increase in bone density was 6.3%. If you did a bone density by QCT, you would see around a 20% increase in bone mass because of what we call the volumetric increase in bone density that you can appreciate with teriparatide only by QCT scanning, a method that we don't use for measuring bone density today. Interestingly, if you compare this vertebral strength, as was done in the FACT study as seen on this slide, with teriparatide in the yellow bars with alendronate in the green bars, and look at the 18 months, and you can just skip the 6-month study. But after 18 months, you can see vertebral strength based on finite element analysis was about 21% higher with teriparatide, and was only about 4 or 5% higher and non-significantly higher with alendronate, indicating the increased strength of an anabolic agent such as teriparatide compared to an anti-resorptive agent such as alendronate. And this strength increase is far greater than the difference between the average density increase, which you can see in the second set of bars. The increase in bone density is greater with teriparatide, but the increase in strength is even disproportionately greater, and that's because of the geometric effects that an anabolic agent has on thickness, for instance, of trabecular struts, which has a significant effect on strength that's unappreciated by measuring a routine bone density test. There's a lot of work going on with teriparatide to look at what might predict response, bone density response, and one of the markers of bone turnover that seems to be the best in terms of predicting the effect on bone density is this P1NP, which is a marker of osteoblast function. And you can see the effect of teriparatide on P1NP at baseline 3 months and 6 months. And you can see almost 150% increase in P1NP, a marker of bone formation with treatment with teriparatide. You can see that the increase in CTX, which is on the bottom in the open circles, is much less than the increase in a marker of bone formation. So this marker of bone resorption is less, and that's what we call the anabolic window, where bone formation exceeds bone resorption in therapy with teriparatide. So it turns out that the best predictor of increase in bone density is the change in P1NP from 0 to 6 months. So you can actually get an early read on the effect of teriparatide by measuring a P1NP at baseline at 6 months. All right, this slide is looking at our new National Osteoporosis Guidelines. Not so new anymore. They were published in 2008, and those 2008 NOF, National Osteoporosis Foundation Guidelines, recommend treatment in patients who have a hip or spine fracture or have a T-score in the hip or spine less than minus 2.5. And then 3, if a patient has osteopenia, a T-score between minus 1 and minus 2.5, the recommendation is to apply the FRAX model, which is a model that predicts 10-year absolute fracture risk for both hip and major osteoporotic fractures, and the NOF recommends in the United States treating patients with osteopenia if their 10-year hip fracture risk is greater than 3% or their major osteoporotic fracture risk is greater than 20%. And what this study did was look at a longitudinal group of patients from GLOW, G-L-O-W, the Global Longitudinal Osteoporosis Study in women who were not treated during this trial, and apply the FRAX model and see what percentage of those patients were treated at some point during the study. They weren't treated when they enrolled in the study. And as you can see, if you apply the NOF guidelines by FRAX score, if you look at treatment recommended based on 10-year probability of hip fracture greater than 3% or 10%, only about 64% of the patients who qualified for treatment were actually placed on treatment. And so that represents under treatment of patients based on the new NOF guidelines. And I encourage you all to use the FRAX model and use the NOF guidelines to help you make treatment decisions. This is an important tool in helping us make treatment decisions, but it is only a tool, and it's not the absolute. There's lots of caveats to using FRAX that we all need to be aware of. But I think this shows you that there's some probably under treatment, and there may be some over treatment in patients based on using 10-year absolute fracture risk in FRAX. This slide looks at the use of bisphosphonates for the prevention of glucocorticoid-induced osteoporosis in patients with rheumatoid arthritis. And this is from administrative data from Canada in 37,000 rheumatoid patients who had 21,000 glucocorticoid doses, which were defined as greater than 3 months and greater than 5 milligrams. And during those 21,000 courses of glucocorticoid therapy, about 8,600 or 40% received a bisphosphonate. So there was probably underutilization of bisphosphonates for the prevention of GIO in RA patients, at least in Canada. The good news here is before the year 2000, about 33% of patients who met these criteria were treated with a bisphosphonate. But after 2000, almost 50%. So it looked like Canadian physicians at least were getting better at using bisphosphonates for prevention of GIO. And remember, in 2010, the American College of Rheumatology published guidelines which recommend treatment in all subjects who were treated with a glucocorticoid dose greater than 7.5 milligrams for more than 3 months. And if they were at lower doses than 7.5, treatment was recommended based on the FRAX 10-year risk model. And I refer you to the paper in ACNR in 2010 on that subject. What about adherence? If you think about it, our assumptions were probably when we started using zoledronic acid back in 2007 when it was released, that adherence would be better because than with oral bisphosphonates because they come into our infusion center once a year and we're much more likely to capture them. Well, this study looked at adherence to both intravenous zoledronic acid and intravenous ibandronate in a Medicare database. There were 15,000 new users of ZA and 7,000 new users of ibandronate. And when you look at this administrative Medicare database, only about 65% of ZA users got a second dose or persisted beyond 1 year. And interestingly, only 34% of IV ibandronate users persisted beyond 1 year. So although the persistence for zoledronic acid at 65% is greater than oral bisphosphonates at 1 year, which is about 50%, it's still not good. And that kind of problem probably needs to be addressed with some type of system approach to your practice where you are sure that patients come back for their 12-month ZA infusion. The factors associated with adherence, interestingly, males more than females got their next dose. Older patients over 85 got their next dose more often, glucocorticoid users, and patients who had prior fractures. And a kudo to rheumatologists, patients who were infused in a rheumatology center were more likely to come back for their second infusion than if they were infused in an oncology center. What about treatment of osteoporosis after hip fracture? This was a study, and you can see the abstract numbers are all for these slides on the bottom. This is abstract 870. This group looked at hip fractures in a public hospital in Ohio between the years 2000 and 2010. There were 420 patients evaluated for osteoporosis treatment who had a hip fracture. Median age was 80, and about 27% of all hip fractures in this group were male, so we shouldn't forget that males have hip fractures too. In these 420 patients, only 13.8% had a bone density after discharge, and only 19% received treatment, and notice that only 8% of males got treatment and only 23% of females got treatment. So we're certainly not doing a good job, and this is not unique to this hospital. This has been found in multiple studies over multiple years. So evaluation and treatment after hip fracture remains low. So the last slide here is an interesting slide from the group, from Fred Wolf's group, on their large database looking at reduction in myocardial infarction in bisphosphonate and calcium and vitamin D treated rheumatoid and lupus patients. And some of you may be aware there's a pretty significant controversy going on because several studies recently looking at data from several large studies, including the Women's Health Initiative, showed that calcium supplementation was linked to increased cardiovascular risk. In epidemiologic studies, bisphosphonate use actually have been associated with reduction in mortality, especially in, for instance, the Horizon trial, where mortality after zoledronic acid infusion was significantly lower. So in a large group of patients, 155,000 semi-annual observations and 23,000 patients with RA or lupus, 93% had RA between 2002 2010. You can see the survival rate here for no treatment on the bottom was about 96% over 10 years. The supplementation with calcium and vitamin D resulted in an improvement in survival. Bisphosphonate and calcium, a further improvement, and bisphosphonate, calcium, and vitamin D resulted in a further improvement in survival. So it appeared, at least in rheumatoid and lupus patients treated with calcium and vitamin D, and especially with bisphosphonate, calcium, and vitamin D, that mortality was less. So there's more randomized controlled trials that need to be done, I think, to sort out the effect of calcium and the effect of bisphosphonates on mortality. So that's my last slide, and that is a brief summary of what I consider interesting and major information that occurred in the 2011 annual American College of Rheumatology meeting. Thanks for joining.